Well, welcome. Tonight we're going to talk about a very sensitive subject, but a very critical subject that we stimulate conversation around. Because too many people suffer for all the wrong reasons. Why don't we start with an introduction?
Good evening, Al. Thank you for having me. My name is Diego Illianes. I'm a physician, a urogynecologist that specializes in a pelvic floor condition of women.
Now, when you say urogynecology,
Yes, it's a good question, though.
because the first people say Euro, E-U-R-O, so you only treat European women?
Right. No, it's a URO, like from the urinary tract, and gynecology from women's health, right? So it's a subspecialty of obstetrics and gynecology, but also a subspecialty of urology. So how do you get to be a urogynecologist? You do a residency after medical school. You do a residency in either either obstetrics and gynecology or urology, and then a subspecialization. So we also call it a fellowship after residency.
But Diego, by the time you get to practice, you're ready to retire.
It is a long journey, but very gratifying nevertheless.
So now, what are the most common ailments that women exhibit when they come to you?
Mainly, they come in to see me because of urinary incontinence, bladder leakage, or sometimes bowel leakage, fecal incontinence, and also pelvic organ prolapse or a weakening of the pelvic floor. And we can talk about what exactly the pelvic floor is that allows the organs that sits in the pelvis, like the uterus and the vagina, to protrude.
But now, do people really understand? I mean, it's a terrible question,
It is.
but do people understand what causes a collapse or prolapse of the pelvic floor or the vagina?
Not until we explain to them. First of all, it's a very sensitive topic. It's very private and many times embarrassing to bring it up even to relatives sometimes, and then to discuss and say, I will go to my primary care provider to discuss this. And then it starts the conversation with the primary care provider, and then maybe their obstetrician and gynecologist, the OBGYN, and then to us. But by the time they get to us, I feel that half of the patients still don't really understand what's happened. It's a very complex, tridimensional anatomy.
Well, I mean, in men, it's ED.
Right.
That nobody will talk about, oh my God, there's something wrong with me.
Exactly.
In women, the urinary incontinence seems to be just as sensitive, but it's common, isn't it?
It's extremely common. It's estimated that more than 200 million people in the world suffer from urinary incontinence or bladder leakage.
But if you bring it close to home, 100 women over 40, how many would suffer from urinary incontinence?
At some point, more than half of those women will have some type of urinary
So
incontinence.
it's not something that it's going to be sensitive, but you
Correct.
don't want somebody feeling embarrassed because one out of every two women over 40 have some level
Correct.
of issue.
Correct. And it's a very, what we say is under diagnosed. And it's also because if underdiagnosed, it's undertreated. Many of these women will live another decade and another decade without having the problem either diagnosed first or treated, which is what it makes it worse. Then that half of the population becomes probably three-quarters or two-thirds of that population suffers towards their 60s, 70s, and 80s, and the 90s even. It's one of the major reasons of nursing home referrals at this point because of when they're 80s or 90s because they can't really control the bladder.
Now, is it safe to say that this is not something anybody should be embarrassed about? It's not something they did. It's, like you say, one out of every two people.
Correct. That's how I start the conversation many times with these patients. It's nothing they did, it's just they're multifactorial, so multiple things can cause it. Sometimes even pregnancy and delivering having a vaginal delivery, certainly it could be a predominant factor, but not the only one. Patients may have occupational exposure, for example, lifting, that it can cause the weakening of the pelvic floor. And sometimes even genetics. One may be born with a genetic predisposition to a weak pelvic floor and a leaky bladder.
But I would think the most prevalent cause would be pregnancy.
It is. It is the most common one in patients who have even one of the worst type of incontinence. They're usually patients who had pregnancies and had vaginal deliveries.
Now, you mentioned that, okay, at 40 years old, a number of women will start to have an issue.
Correct.
And a lot of them out of, I don't want to say ignorance, but not understanding what's going on, out of embarrassment, because they don't understand that there's nothing they could do, there's nothing they did. What happens if you don't do anything? You just ignore it.
It most likely, as you get older, it may get worse. And the reason is because all these tissues are supported by estrogen. So estrogen provides elasticity and resistance to the pelvic floor musculature. And as you go into menopause, if a woman goes into menopause, decreases the level of estrogen, and thus decreases the level of support to the pelvic floor structure. So most likely will get worse, but nobody really knows for sure.
So it's not just like, you think about some of the issues women run into when they have sensitive tissue, like vaginal tissue that dries up.
Right, exactly.
It makes it painful to have any activity.
Correct. It goes hand to hand. It's even a new syndrome or a new name to a syndrome that we knew for a long, long time. It's called lower urinary tract syndrome of menopause. LUTS is a very long name, and they go hand to hand. One is the dryness with intercourse, or the irritation of the vagina and the outside of the vagina with intercourse, or even the bladder problems and the bladder leakage.
But now, well, I'm not a woman, but I'm 40 years old. I start leaking. A lot of times you hear when people sneeze.
Correct.
And as silly as it sounds, you're putting strain on your body, and it can happen.
Exactly.
I come to you. What can you do for me?
So the first thing I will do is commend you for taking the initiative, because this is not normal. So the major message is we try to tell the community is there is no normal. Maybe culturally, maybe because that's how our parents live through the condition, our grandparents and great-grandparents, thinking that, after you have babies, you will have some problems, and that's the way it is, but it's not.
Well, you have a Spanish heritage.
Correct.
I have a Portuguese heritage. It's all the same, that you didn't discuss problems like this.
Absolutely not. Certainly, it's not a tea time.
It's not something you have breakfast conversation.
Exactly.
But, you think about, my sainted mother, she would never discuss a problem she had.
Correct.
And it just was the way she was brought up.
Correct.
I remember the first time I went out and got tampons for my daughter. My mother almost had a heart attack that I would go out. But in today's day and age, somehow we got to get the message across that you're 1 out of 2, you're normal.
Correct. You're normal. What is happening to you is not normal. So that's the message, especially when you have so many options for treatment. Meaning, and that's one part. The other part is how impactful this is for the quality of life of women. For the time that you said, sneezing, coughing, when we talk about stress urinary incontinence or incontinence caused by exercise or exertion incontinence or bladder leakage, patients that sometimes enjoy the trampoline with their children, and it's an activity that she cannot do that anymore. Or a patient that has to pack extra set of clothing or protective pads for the vacation, for the family vacation trip. Not fair.
But it's gotten, at least it seems like from a observational point of view, that there's more products out there. That companies are accepting the fact that this is normal, and they're making different types of feminine products to help women.
Correct. It's certainly there is a lot of research happening, and companies are noticing that patients are starting to realize that they can take action and they can do something about it.
So now, a woman comes in, you get her to talk,
Right,
which is probably the biggest hurdle you have to get over.
right.
I mean, it's got to be difficult to. I've known you for 30 seconds. Can we talk about if you're leaking?
Exactly.
What treatments are open? What are the options for women?
So the typical encounter, the initial encounter that we have with patients is we go to their what we call bladder diary. We want to learn what happens from the time they wake up, how much they drink, because obviously it goes through the kidney and ends up in the bladder, to how many accidents they have a day. We create an environment that is, believe it or not, ends up being easier to talk. One of the things I tell my patients is, this is all I do. You're not in a dentist office. This is all what I do, and I see that every day. And these are the treatments, for example. It seems like you're having incontinence because of physical activities, or it seems like you're having incontinence because of urgency, the two main types. And we can help you with this treatment or these other treatments, most of the time conservatives, starting with diet. And then one of the things that I really try to focus on the patients is as a pelvic floor in general, as a complex structure. And one of the questions I ask is, do you know that you came to see me today because of bladder leakage? Do you know that 1 out of 3 patients like you with bladder leakage have bowel issues
They'll
as
have
well?
fecal issues too.
They will have fecal incontinence as well. Correct.
So now, if somebody asks you, there's a lot of activity going down there. What happened? You know, what made my pelvic floor weaken or
Most likely, I tell patients this is multifactorial, and I reassure them there is nothing wrong you did, not even for activities. I have patients that they have occupations that they lift weight, yet it may be a contributor. I have patients who have 5, 6 children vaginally through vaginal deliveries, and I tell them it's very hard to tell if that was where the damage occurred or where the weakness happening, especially because we know also it could happen even to patients
who
without,
haven't had kids?
exactly, without kids or without a really extraneous physical activity. Have a lot of sports athletes that they can have this problem, for example, and there are patients that they're not very active and they still have it.
But what's actually happening? I mean, we read about surgeons using mesh
Yes,
to kind of hold everything up,
exactly.
but that didn't seem to work real well.
No, it was a very interesting concept. In many areas, the mesh scenarios that they were out there for about 10 years did not really provide what patients really needed in many occasions. Yes, some meshes are good. Some treatments with mesh are really efficacious and what patients needed. But others, not necessarily so, causing more problems than solution. So the whole point, the whole idea is to just understand, or what we try to explain to patients, understand the anatomy of why this is failing, why they're having these problems, and why other people don't.
Is it that it's stretching, or, you know, when you say prolapse, or people look and say, what does that mean?
Right, it's a combination. It's a combination of things like the analogies that we sometimes use is like a boat on a deck. With or without the water, these boats are held by ropes, and those are the pelvic organs, and the ropes are very thick ligament or connective tissue that we have to hold that boat up. And if you go up and down with the water, then these ligament structures like rubber bands will stretch out, and then with time, if you live decade after decade. And interestingly, one point that I didn't mention is how active patients have become and will become in the future. You know, 50 years ago, an 80-year-old patient would not play tennis. Like I do have many patients these days that play tennis, 80s, 85, 90s. Ping pong, for example. That was unheard of 50 years ago. So you put those tissues into a much more prolonged, with time, stress as well as with activity.
You know, you think about it, and as we get older, You know, our grandparents or our great-grandparents never expected to live 70, 80 years.
Right.
So you start thinking of all the medical treatment and you say, well, something's going on because we're having to use a lot more drugs. My mind, yeah, I'm getting older.
Right.
And if
Exactly.
I live to 70 and, or 80, let's hope, and my dad only lived to 70, the odds are I'm going to have more problems than him.
Maybe, maybe not. Depending on how much advancement treatments are out there. Year after year, we see a significant improvement on what we knew 5 years ago compared to what we knew now.
So now it's interesting because, you talk about the ligaments holding organs together,
Right.
but it's not just the vagina down there.
Right.
Do you have the same issues with the colon, with the bladder?
Exactly. So the pelvic floor, picture the analogy like a human pelvis is like a vase, which is open at the bottom. Originally, that's the bony pelvis. And then the pelvic floor musculature comes in, which is like a plate, is a super thin, like a paper plate, that closes that vase from the bottom and allows organs, as you well mentioned, Al, the urethra or the tube where we urinate from, the vagina in the middle, and then the anus and the rectum on the back. So the muscles reorganize to allow the passage of these structures, right? So it becomes a very, very functional region of the body, especially because, as you mentioned, you have three different systems there. The urinary systems on the front for the bladder and the urethra in charge of the urination, then the defecation on the back, and the vagina, very important for childbearing and deliveries. So multiple reasons where you could have trauma and origin or reasons why you could have trauma in that area.
Now, when you talk about ligaments holding one organ,
Right.
I mean, we're not talking a huge space here. Everything is very compact.
Correct.
Dr. Diego, if you start pulling back or changing, don't you affect how the geometry of the other organs are set?
It does, and one area will take over the other. An example is when I try to explain this to patients, it's very difficult because A is three-dimensional, and B, you cannot see it. It's not the same if I tell you, look at your fingers, have your fingers like this, and you can really, or look at your biceps and touch your biceps, right, when you do a curl. But for pelvic floor, it's different. You can't really visualize it. So it's exactly as you said. Like, if one thing affects the other, put an example, constipation. A rectum that is full of stool will occupy about half of the space that it has to be shared with all these organs, right? And the space is so small as it is the baby's head. That's how big the vase is. It will not be larger than that. And in that you have to fit vagina, bladder, and rectum. So it has to be a balance between all those to try to. That's why when we talk to patients about one concept, for example, we talk about urinary incontinence and how to work with the bladder, we always work with the bowel as well. A good bowel regimen to make sure we create the room in that pelvis.
Yeah, well, you have 3 roommates living in one room.
Exactly.
You can't do something for one and not affect the other 2.
It has to be a balance, a homeostasis that we call, right?
But now, when you talk about constipation,
Right.
if I'm taking over a third of the space before I evacuate my bowels,
Correct.
how do I urinate?
Exactly. What happens is patients will have what we call urinary frequency because the bladder cannot expand because it's occupied most of the space. Then they will only be able to hold small volumes of urine, and that triggers a spinal cord response to say, go to the bathroom, go to the bathroom. Go. So they start having that urinating every hour during the day, and then it becomes bothersome urinating every hour during the night, and then they don't sleep. And that's one of a huge impact to, again, quality of life, what we always try to emphasize.
I can see that because the body is going to fight off the uncomfortable feeling.
Right.
So if you're constipated, it's not as easy as just go pee.
Exactly.
So for the body, the least course of resistance is to
Exactly.
force you to pee a lot.
Exactly. That is the point.
But if I got to wake up every hour, I'm not going to get any deep, good sleep.
Right, and especially when all your systems are intact, right? If your brain and your spinal cord function well, the typical human won't really pee on the bed. Will just wait, but it works out such a perfect mechanism that it will wake you up from a deep sleep to go to the bathroom.
Every hour.
Every hour, because there is no volume. Imagine there is no rest. It's quite gratifying when we can alter that, we can change that in many, many occasions. And all of a sudden patients come in to see you follow-up, rested. You can see them in their face.
Oh, that's going to be wonderful.
Yes.
But now, how do you treat it? I mean, I could see a mesh. If you're getting a collapse, a prolapse, you put the you hold it back up.
Right.
You tighten the ligaments. Okay.
Right, exactly.
It's a very basic way of putting it, but what else can you do?
Right. So for urinary problems, it's very interesting. I always like to start, and I say this to patients from the very beginning. We start with conservative management. I tell them you don't really need surgery right away, despite we are considered pelvic surgeons. It is the best thing that you can offer to the patient is no surgery first. What we call conservative management or behavioral modification. Sometimes it's as simple as changing the diet or taking a look at the diet. Not so much of what we drink, but the volume as well. Exactly. I see you putting down the coffee.
I'm putting down my coffee.
Caffeine is a well-known irritant to the bladder. So just the caffeine alone can cause you to go too often, but it also has to consider the volume of how much of fluids are we consuming. In part is
I'm glad I'm an old man because sitting there drinking my coffee this size would be a real problem.
right. Sometimes it's also the amount you drink, but also the quality. Like we discuss with patients bladder irritants, and I tell them you don't have to really switch everything to water and only drink water, but I say look at what you're drinking, write it down, and then see what you can eliminate or replace for a week or two and see if you get better. I have a good anecdote. I had a patient that was 72 years old, and she came to see me with urinary frequency and urgency and urge incontinence. So we also call this overactive bladder, not letting her rest, not letting her do normal activities. So we sat down and we wrote what her diet was. And it to me seemed like very healthy, like normal amounts of food and normal distribution of the liquids. But she loved her orange juice in the morning, freshly squeezed orange juice. So I said, well, that's really healthy. I love orange juice myself. She did not drink coffee. So I said to her, why don't you just replace it for 2 weeks and see what happens? And it turns out that her bladder had become very sensitive to citrus, to the acidity present on the orange. It doesn't mean that you have to completely eliminate it. She changed the orange type, as it happens with apples as well. There are different type of, I learned that acidity in different fruits. So she changed to red oranges, and then...
Is it less citric acid? Or?
Apparently, never had the problem again. So she didn't have surgery, we didn't have to do medications, and she was very happy after. So that starts with the behavioral modification. Then we teach them how to retrain the bladder. We know this as babies.
Retrain the bladder.
Indeed. I say to them, it's not like potty training, because that's the wrong
It's the opposite.
But you say your bladder had lost control. There's a lot of reflexes going on between bladder, spinal cord, and brain that it tells. The bladder says, I'm full, send the signal to the spinal cord, and the spinal cord sends a signal to the brain and says, start looking for a bathroom.
Yeah.
And then we can go sit there in the toilet. So it's very well coordinated. But sometimes loses the control. And what happens is that we teach patients how to regain it by spacing out the voidings, trying to do exercises. Another big topic is Kegel exercises or pelvic floor exercises to help them do or regain control or strength of the pelvic musculature.
So doing Kegels not only helps the vagina, but is going to help the urinary muscles?
Correct. I'm a big believer, and I always recommend patients. We work very closely with pelvic floor physical therapists. They're specialized women that they do extra training in pelvic floor to train the muscles, retrain the muscles. But it won't just help the vagina it has multiple benefits. It can help the rectum as well. It can help urinary leakage, and I believe also in helping them controlling urgency of urination even without leakage.
But now, what kind of exercise? When you say you have different exercises,
Yes, those are the ones that I always say, you probably should visit one of our physical therapists because they can, A, help them understand where those muscles are because those are the ones that you cannot see or even feel sometimes. And then go into routines or teach them different routines of how to activate them. There are simple exercises that a patient can do, like trying to feel the back of the pelvis and lift or trying to close or preventing gas from coming out, for example, or doing the front, like trying to squeeze and prevent the urine from coming out. Those are simple exercises that sometimes I tell patients start doing them at home until the physical therapy can see you.
and those kind of exercises you can do in the privacy, because again, you get the sensitivity.
Absolutely. It's all like any other exercise in the gym, consistency and repetition, right?
Yeah, but you're not going to a gym to look for the pelvic floor room.
Correct. Although that's a good idea, Al.
You're still dealing with the sensitivity.
Exactly. So it's private. And the good part that once they are activated or patients start doing them, no one can really tell. If you're doing the right exercises, which you need instructions sometimes for, and most patients don't really know where those are, which one are the right exercises. If you're doing them right, no one can tell you're doing them. Number one.
But you get to a point where, I'm assuming this is all mainly mature women.
Not necessarily.
Really?
Oh yes, it goes all across the spectrum of ages. See, it's another assumption that most patients will say, "Oh no, that's because I'm getting older." It doesn't mean that.
So how young are your patients?
From 15 years old
Oh
to
my God.
99, 104 was my oldest
Well,
patient. Yeah.
But I would never have guessed that pelvic floor is, because 15 they have, typically I wouldn't think they've had children.
Right, but it goes back on the theory of the multifactorial. So in a patient,
Genetics could be working against
exactly,
you there.
exactly. Some collagen structure problems, or that the patient has more elasticity on the tissue and it's unable to hold.
But you get to a point where your partner just has to understand this is nothing you did.
Right.
So setting time aside, I'm a fat old man. I'm supposed to be doing more exercises, so I set up a gym.
Right.
My family tells me I don't use it very much. But, you have to understand that your spouse, whatever, your wife, your significant other, this is important for her overall health.
Exactly. So what I tell patients is to do them in the privacy of their house, even while doing the usual activities, so the brain will remember to do them. For example, I teach them every time you brush your teeth, you can do 15 squeezes. Every time you comb your hair, you can do it. Or some people will recommend a red light. Every time you commute to work and you see a red light, you do a couple. By the end of the day, you have activated this muscle.
So it's almost Pavlovian. You train yourself
very much
to respond to a certain stimulus.
Exactly. I think it has to be started at as early as a woman can, to be very conscious of their pelvic floor and aware of what good they can do if they practice exercises.
So exercising can tighten up the floor.
Exactly.
Help with the bladder leakage.
Correct.
Now, what causes the other organs there to prolapse? Or
it could be, for example, patients with severe constipation. They bear down and they push and they increase the pressure in that area so much that it allows not just the vagina, but the rectum can prolapse through the anus. The same thing, it can happen, for example, with the vagina. The bladder is softer than a hard rectum or a hard stool in the rectum. So the bladder typically will prolapse through the vagina. What patients will refer to as a bladder dropped. But those are the most common type of prolapses. The front wall is the vagina or the bladder drop. The back could be the rectum, and then the top where the cervix is, where the uterus is. In many patients, it could be just one compartment, like the top, the front, or the back. And in many other patients,
Could be
every
multiple.
multiple, right?
But now, if you're suffering from hard stools, and obviously the pressure to remove them
Right,
is not helpful,
right.
what can you do?
A couple of things. Sometimes we talk to patients about a rigorous diet, like high fiber diet, working hands to hand either with physical therapists or with their gastroenterologists as well, to make sure that at all possible try to normalize and have frequent bowel movements, which is something that it will prevent the hardening of the stool.
Oh, I was going to say, you have a choice? Somehow I never thought, okay, it's 2 o'clock, it's time for a bowel movement.
Ideally, going into a routine, it is one of the strategies that we use, that we teach to patients. Either early in the morning or making sure to try to make them regular. As I said, with special diets, that we have a list of recommendations of what we can do, not necessarily using medications, but maybe just improving their diet.
What kind of diet? Eat weeds? I mean,
Ideally, what we say to patients is a good, healthy bowel habit will have about 25 grams of fiber a day, which is, if you're going to eat that in regular vegetables, it's impossible. It's like a pile of food on a
I was
table.
going to say, that's a bucket. I'd feel like a horse where they put the bucket.
Even more than that. 25 grams it's an extraordinary amount if you consider just food. So we tell patients to get supplements. So concentrated fiber in the forms of supplements, for example, there are several brand names, but I always tell them, go to any of the pharmacies. It could be Walmart, or it could be your regular CVS, your regular pharmacy, and ask for go into the GI aisle and look for fiber and look for 25 grams a day. Sometimes gummy fibers are
Gummy fibers?
gummy fibers are very common, very easy, because you don't have to mix it in the morning. You just carry it with you.
The poor gummy bears. First it was cannabis gummies, now gummy fibers.
And you can get anything on gummies these days.
Wow. I had not thought about that.
I always say it's good for men and women. Many times I recommend to the patients, you and your husband should do this, because our Western diet is typically poor in fiber. And it's always very beneficial, prevents a lot of colon or bowel conditions.
I was going to say, I think it'd be hard to go home, look at your husband and say, you need to eat this because it'll help your pelvic floor.
Right. No, it's just it prevents conditions like diverticulosis, or either there are some studies that believe it could reduce the risk of cancer, even of the colon. So well-balanced diet, 25 grams. Hard to get. I always tell patients, when you go and do your shopping and you checked on on the boxes of the cereal, read about it and see like how much every item contains.
But now, realistically, you would be providing a lot of support if you and your spouse got in a routine of when to do whatever exercises.
Correct.
Because all of a sudden, I mean, one, you're reinforcing the fact that, I mean, it's terrible, but you're one of two women. You're one of the 50% that's going to suffer from this.
Exactly.
But number two, I want to help. I can't do anything, but at least I can help by being there and doing the exercises.
Yes, indeed. Right.
I'm learning something new. What brought you into this field? Of all the fields, I mean, to become a urogynecologist, you're almost retired by the time you're done with school.
Right. That's a great question. I think it's the gratification you feel by improving the quality of life of these patients. In part is how attractive it is and technically challenged some of the surgical procedures are, but at the same time how good it is, or how good it feels when you can make a patient better without surgery, applying a lot of medical knowledge without surgical techniques into it's day and night. As I was mentioning before, a patient that all of a sudden is able to sleep.
But your title, pelvic surgeon, almost by definition, I think you are going to grab the knife first.
That's what I always try to explain to patients. And 50% of what I see in the clinic, I reassure them, and I can feel the relief when I say, you don't need surgery for this, but I'm glad you came, because there are a couple of other things that we can do.
Well, I mean, that's reassuring because it ought not be surgery because you're a surgeon.
Right.
It ought to be surgery because that's the best option for the patient.
Right, and many times, in many occasions, the surgery, it's not the end route, but it's the most advanced treatment option when patients have failed other treatments.
So here you are, you're trying to decide what you want to be when you grow up or when you almost retire. What do you have to go through for your academic career?
So you have to do the medical school first, and then residency, which it could be
Well, I mean, you're doing undergrad 4 years,
undergrad 4 years,
medical school 3 years,
4 years of
4
medical
years,
school.
so that's 8.
Right, and then you'll do 4 years of residency,
That's 12.
or 5 years if you come from urology, and
That's
then
13.
2 or 3 years of fellowship.
16 years before you can
16.
start working?
I threw 2.5 more years of research. So I did a basic science research in between. So ended up being a long journey, but
So almost 20 years
Almost
before
20.
you could say, I'm ready to go to work.
correct.
Wow.
But it goes by very fast.
Yeah, so does in life. So you started in Argentina?
I studied medical school in Argentina, and then after a short period of time in Spain, I came here, and I did my residency and fellowship here.
How did you end up in Milford?
I trained in Central Massachusetts. I trained at UMass.
UMass?
I did my residency and fellowship at UMass. And then I practiced in the area for about 7-8 years. And then I went east, went practice in Boston for about 2 years, always with the relationship with Milford Regional, which is amazing. The people, the geography, and the institution, we always kept connected. And then at some point while I was still in Boston, we kept conversations, and the population needed me more here. And that's how I came full time.
Well, it's always amazing to me, because I grew up here in Milford,
Mm-hmm.
when the medical center was a little red building. You know, it was a tiny little place. To look at what it's grown into.
Mm-hmm.
And, you know, my hat's always been off to Frank Saba first and now Ed Kelly
Correct.
and Pat and Peter. You know, it's like what they brought to us
Correct.
is amazing, because for a community hospital, and, you know, to us, Milford's a big city, 30,000 people. Seriously,
Right.
we're a small town, and to have a tie to UMass, to have some type of relationship with one research center is very, very impressive. We have 4.
Right.
You know, so when I hear people like you that were drawn in from the gravitational pull,
Right.
you know, from UMass and Dana-Farber and Brigham,
Or from Taft, I came from.
or even better,
Right.
you know, again, it just amazes me.
Right. It's there is a lot of feeling. There are people, excellent leadership, who are very committed to the community. That's the way I see it.
Now, when I think about your choices, you could have gone anywhere.
Correct.
Why Milford?
Well, I have half of my family is from Central Massachusetts, so my 2 daughters are from Massachusetts. So it's not and I spent more than almost half my life here. So it's that you start belonging, and with that comes giving back, right?
I've always been amazed when I talk to some of the medical staff, and I've been here not as long as my colleagues. I've only been here 20 years. And it just amazes me, because the level of talent we have in the Milford Medical Center, they could go anywhere.
Right, right.
Wow. So I admire the fact that you look at all the options.
Correct.
But when it comes down to having to do surgery, what's the most common surgeries that you perform?
Well, because of urinary incontinence is so prevalent, it's probably targeting the treatment or the management of urinary incontinence. So there are two major types of incontinence: urgency, urge incontinence, and stress incontinence. Stress incontinence is these days surgically managed by what they are mid-urethral slings, or the usual old traditional slings. They are more than 20 years out. They are with excellent outcomes. Or
Now that's there to hold the bladder up to keep the pressure from forcing you to go to evacuate.
it's mainly to support not necessarily the bladder, but to support the urethra, the tube that empties. And the other procedure is called bulking injection. So the idea of bulking injections is to provide some resistance to that urethra in a very minimally invasive procedure. There are no incisions. It's all done endoscopically through the opening of the urethra in a day surgery operation where the patients resume to normal activities the same day, actually, without downtime.
Now the urethra isn't that long, is it?
It is not. It's about 4 centimeters. So
I was going to say it's less than 2 inches.
But we have this device that is very specialized. They have a very small telescope that it goes into the urethra with very small needles, and injects a material that is well studied, well known, with highly efficacious to treat
What
stress.
kind of material?
It's a polymer that is made about 97% water molecules and 3% of a polymer that it becomes some sort of a viscous gelatin enough to allow urine to come out, but only when it's necessary. So it provides good protection for the accidents.
So you're adding basically some resistance.
Exactly.
Huh.
Which with time had gotten wider and wider, and this is kind of narrows up a little bit.
And how long does a treatment like that last?
We know that for recent studies, patients are satisfied for about 7 years, but that's the longest that we have looked. I think as we continue to look, that may be longer than that.
But for minor day surgery, I mean, not that any surgery is minor, but to get 5 years of relief,
Right.
that sounds fantastic.
Absolutely. From improving, it's again, quality of life of sometimes not having to wear pads anymore, or going back to the trampoline without leaking urine, restoring daily activities that they were put on the back because of the embarrassment or because having to pack extra clothing, right?
Yeah, I mean, I've seen more and more advertisement of good-looking panties that absorb and pads, and so it seems like the market is getting more friendly.
Oh, absolutely. And unfortunately, a lot of these patients must know that they may not need to incur in this expensive if they get the problem fixed. You know, the pad industry is about $6 billion industry in this country alone. But it's we have to tackle the root of the problem. The other surgical management is that from the urge incontinence is what we do. We do Botox injections into the bladder, or we do something that's called sacral neuromodulation. So we're able to modulate the contractions of.
I mean, you're putting botulinum in there?
We put Botox inside the bladder. One of the several properties of this toxin, and the other is what we call PTNS, or peripheral tibial nerve stimulation. Sometimes with a very small acupuncture needle in the ankle of patients can stimulate again the pelvic floor and cause some bladder relief.
What does the botulinum do?
It prevents the bladder from squeezing unnecessarily, or when the patient doesn't really want to.
Okay, so it relaxes the
Exactly.
muscles to squeeze.
The tone of the bladder muscle, right.
Wow.
Yes, well studied. A lot of relief to many patients that qualify for that.
And you said you're doing acupuncture in the ankle?
So it's a procedure that uses an acupuncture-like needle that is connected to a pulse generator, and it essentially sends electrical impulses into the bladder nerves or the pelvic floor nerves.
From my ankle?
From the ankle, right.
Okay, I'd have to try, because if you started going, I'd say, excuse me, you missed.
Right.
You're too far south.
Yes, it's a technique well studied that we do for patients who cannot have more invasive surgery. they have to come to the office for that. They have to come once a week. We don't know really long term what the efficacy is. For that, we use the pacemaker, which is a similar idea of stimulating the nerves of the bladder and the pelvic floor, but using a device that is very similar to a heart pacemaker, but is implanted in the patient's lower back.
Oh, wow. So now, when they have fecal incontinence, things you do there could affect urinary incontinence.
Absolutely, absolutely. One of those devices, for example, the neuromodulator or the sacral neuromodulator, was FDA approved in 1997. And after several years, the FDA looked at this and they said, wait a minute, in 2012, they said, a lot of these patients you're treating for urinary issues are not leaking stool anymore. How this works. And that's when we learned that the same devices actually used for the management of fecal incontinence as well. And as we were mentioning before, if one patient with fecal incontinence out of three with bladder problems, you will be treating a really wide range of the population with the same procedure.
So again, the biggest thing is get over the embarrassment.
Correct.
And understand 1 out of 3 out of half the women over 30, 40 years old.
Exactly.
I hate to say you're not overly special. You're just one of half, 20% or so of women who go through this. The sad part is you don't have to go through it.
You don't have to go through it. And as providers, we have to keep learning in how to make patients comfortable, how to ask the question. We are in part guilty that we don't really ask a lot. I think we're getting better, presenting the patient what is the best thing that they can do, presenting to patients that there is help out there. You don't really have to live like this.
Well, I would think the trends in modern medicine, when Milford first had, when I first was born in Milford, I could trace my coming to Milford from one of 4 physicians, Cicchetti, Mastriani. One of those 4 brought you into the world, and they would remind you if you didn't take care of yourself, they'd take you out.
Nice.
But there was only 4.
Right.
It was a tiny little group of people.
Right.
They had the time to spend 30 minutes, 40 minutes walking through. Now you start hearing about primary care physicians that are being pushed to spend 13.3 minutes per patient. How do you even get comfortable with somebody?
Right, it's true. It's a system, right? It's how the system is managed in different situations. One of the things I teach at the medical school, and I still teach residents and medical students, and one of the things I tell them that every individual patient should feel that they are the only patient of your day. It's very hard to accomplish, I know that. But that's how we have to focus and narrow that little minutes that we have with them, especially going into the right areas to ask the right questions. It's a challenge. It's not easy. And as I said, we're still working on it and getting good at it.
Well, especially where you're dealing with, when I had my nuisance, my quadruple bypass, it happens, okay, I don't know what I did, but I've got 3 arteries clogged, and it is. You weren't talking about areas that, I'm embarrassed about.
Right.
You weren't talking about areas that I'm not educated on.
Correct.
I'm not saying I'm illiterate or I'm less than intelligent, but just, you don't have breakfast conversations about urinary incontinence.
Exactly. So one of the things that we try to tell patients when they come back, for example, and they say to me, thank you so much, I didn't know, if I have known, I could have done this way earlier, right, in my life. And I tell them, it's your job now to just tell people this is not normal. Because sometimes in some conversations, there will come interactions that I tell them, you could speak up and say, there is help. You don't have to come and see me, but you have to bring it up to your primary care provider and involve a pelvic floor physical therapist from the very beginning. They will tell you, they will be able to tell you what can you start doing.
Well, it's funny because the soccer field sidelines are the common denominator that most families share.
Right.
But again, it's not something you're going to be talking about.
It's always, exactly.
So the hardest thing is somehow to get the message out to people that this is not something you did.
Right.
This is not something that you could have changed.
Right.
And more importantly, this is not something you have to live with.
Exactly. There is a lot of treatment options for these patients. Many of them don't involve surgery. There is a combination of two very interesting things. One is it's very private, and the other is that is a very embarrassing condition. Both things.
Now, a lot of people in Milford, but in the area, they're doing okay. But financially, they're not in a position that they can afford very expensive treatments. Is this covered by insurance?
That's a wonderful question, Al, and I get that asked a lot. It is. It is for the reason is many years ago it was probably a lot of debate, and we'll have to quote unquote fight it a little bit more. But insurance and payers have come to realize that if you don't help this woman, this 50-year-old patient, who all of a sudden has to stop her spinning class, or she's not walking with her friends in the morning anymore because she's looking for a bathroom, or because she's afraid of having an accident, she's going to stop exercising. We're going to have to pay more for other health conditions that come associated with not exercising. So in the base of let's get them out there healthy so they can continue to exercise and do normal activity and go to the gym without having the thought of an accident, then we'll cover the treatment so they can get out there.
Well, you think about it. If you plan, and you end up with friends and you're walking with your friends and you say, I know that I can always make it between the Dunkin' Donuts and the donut shop here.
Right.
And you plan your walk.
Exactly.
So that you always have a place. You may not need to stop at the Dunkin' Donuts today.
Right.
But if you do, there it is. And the stress of worrying goes away.
Absolutely. You touch a very good point there. That's actually a description in literature about, that's called mapping. So patients will know from point A to point B, from home to work, where are the cleanest McDonald's or the cleanest coffee shops where they can stop and utilize the restroom. One of the important things that I learned myself not too long ago, that any any business in Massachusetts has the obligation to let a customer use the restroom if they have a medical condition like bladder or bowel leakage, if there are 2 or more employees present in the business at that given time. That's legislation, and not many people know.
But again, Diego, the saddest part about that is that means I got to say it publicly.
True, we have to speak up.
I mean,
but honestly,
I'm more likely to keep my routine
right.
if I know I can walk into this store, the Dunkin' Donuts,
right.
the Pancake House, whatever. Nobody will notice me.
Correct.
It's a clean bathroom because they may have an obligation of a bathroom, but some of the bathrooms.
It's true.
So, the mapping idea is a fascinating concept because that frees the person.
Absolutely. Absolutely.
So, as sad as it is, we're coming to the end of the show.
Wow. It was a really great conversation. I could keep going. We could keep talking.
We could keep going, and maybe in a year or so come back and give us an update. But what would you leave as a message? I mean, what I got away from is if you have a bladder, a leakage problem, and this sounds terrible and I apologize, you're not overly special.
Exactly.
This is not something that you should feel bad about.
Right.
Because you're one of 2 women over a certain age that has this.
Correct.
More importantly, you don't have to live with it for the rest of your life.
You said it all, Al. That's the point. I use the same analogy. If you go to the grocery store and there are 10 women of about your age, just think of more than half of them will have the problem, so don't feel too bad in talking about it. There is a treatment. I'm sure there is some sort of treatment to make your quality of life better by half of, or if not, by 100% of what it is now.
So if I'm a woman beginning with this problem or deep into this problem, how do I get a hold of you?
By calling, I think bring it up to your annual visit, on your primary care visit. That is one idea. The other is calling the main hospital, Milford Regional, and ask for our direct office number. Or online. It's one what we use most of the day, just the usual search engine.
And we have the contact information coming up in the credits. So that, you can always Google Milford Hospital.
Exactly. Milford Hospital.
Milford Regional Medical Center.
Milford Regional Medical Center or Milford Regional Physician Group and urogynecology or pelvic floor. These algorithms, they work in such a way that if you put Milford Regional urinary incontinence, should find me.
Well, thank you for coming on.
My pleasure.
And thank you for helping our wives, our mothers, our friends understand that this is a condition that they can address and live a quieter life, a less stressful life.
Excellent.
And
my pleasure.
As always, I'm always amazed at when I grew up in Milford, when I was born at the Little Red Hospital that we call Milford Hospital, how tiny and how limited everything was, and how today we have a world-class medical center with world-class physicians and surgeons. Thank you, Ed. Thank you, Pat, for bringing everything together so that our families can stay in Milford and be treated. I can't say anything more. I really, really appreciate what you've done for the families here in Milford and what you continue to do. So as always, to our 6 loyal viewers, may God bless. May tomorrow be a more healthy day than today. If you do suffer from urinary incontinence, reach out. Don't live with it. And good night. May God bless.
Not too long since I've been home. Been running all my life just